In this session, we are going to learn about goals and objectives of national health policy. What are those principles of national health policy, and there are certain goals which were decided to be achieved under national health policy. Uh, then national health programs which are being charted out in national health policy, and then, as I said, in brief, we will be discussing about NRHM and NUHM. So, any idea when was the last national health policy came, or by now how many national health policies India had till date? Yes, no. Okay. So we had till date we are having three national health policies. So first one was published in 1983, and then after 1983, second national health policy came in 2003, and the third national health policy came in the year 2017. So no, after another every 15-16 years, government of India, Department of Health, they come up with a national health policy, and then it's something like we have Millennium Development Goals. So before that Millennium Development Goal, we had SDGs. So no, so similarly these Millennium Development Goal were international targets, where as a world we try to achieve certain percentage, certain rates. We try to reduce maternal mortality, infant mortality, neonatal mortality. So similarly, government of India also come up with a national health policy. So the latest one was in 2017, and uh, these previous two national health policies has served as a roadmap or a guiding document for the new health policy, which was released in 2017. So the primary aim of this national health policy 2017 is to inform and clarify and strengthen and prioritize the role of government in shaping the health system. So we already had an infrastructure. How better we can tie the knots? We talk about convergence. How better we can converge with different departments. How we can strengthen the infrastructure. How better we can do health strengthening. So all these nitty-gritties were taken care in the new national health policy. So we have already we are sitting in 2023. So this is 6-year old national health policy for us, but still the guiding principle remains the same, because after 2017 we are yet to get a new health policy, and as I said that this comes after 15 years or so. So we still have some time. We are still midway in the health policy. So this is the guiding document for government of India, and we are working on that. So 14 years after the last health policy, that is 2002. So last was released in 2002. So after 14 years, this new health policy has came, and then as I said, after 14 years or 15 years, a lot many changes happens, in the health indicator. So then we will see in the new policy what all there are there. So first, the health priorities keeps on changing indicator wise, or like our need also keeps on changing. So if you will see in national health policy too, there at that time we had been seeing from our class first that how the epidemiology of the diseases has been changing throughout India. So if 10-20 years back, a public health person would have focused more on communicable diseases, whereas now the shift is from communicable to non-communicable. It does not mean that we don't have any communicable disease. Communicable diseases are there, and new epidemics on communicable diseases will be coming. But we have uh, uh, an increase. We have seen an upsurge in cases of non-communicable diseases also, be it diabetes, be it hypertension, be it cardiac problem. So we have seen a shift in the epidemiology of the diseases. So accordingly, the health priorities has been changing. Uh, uh, Previously there had been a lot of maternal and child mortality, so these has declined in previous years. On these things has been taken in care in the uh, previous two health policies, but still the focus is over there on the new health policy. Also talks about decreasing maternal and child mortality. Okay, as I said, there is a growing burden on account of non-communicable diseases and some infectious diseases. As I said, that infectious disease are still in focus, but we do have upsurge in communicable diseases. The second most important change is in the emergence of robust healthcare industry. This healthcare industry is mostly, when we talk about healthcare industry, this mostly envisages the private sector. So, India is becoming a medical tourism, wherein patients from other countries are coming, and here the cost of treatment is relatively cheaper than compared to other developed countries. So that is the biggest change over there. The third change is in the growing incidences of catastrophic expenditures due to healthcare cost, uh, and because of which we are one of this cost towards health is one of the contributors towards which is taking us towards poverty. So that's why the cost is more towards curative aspect. So that's how the role of preventive aspect comes no becomes very important and pivotal. If we will take care of disease, by preventing them through health education, through changing our behavior, our practices, then definitely we will take care of many diseases, and then we will not land up in spending a lot of money towards curative aspect. So fourth, a rising economic growth enables physical capacity. Therefore, okay. So this is more towards urbanization, rampant industrialization, because of which there is a shift in that diseases what we have already discussed. So the goal and the objectives. The goal of this national health policy is to attain the attainment of highest possible levels of health and well-being for all at all ages through a preventive and promotive healthcare. So again, as I said, the focus is over here on the preventive and promotive healthcare. So this is very much focused. The government is very much focused that if we are going to prevent no, a disease condition and promoting healthy lifestyle, then definitely the expenditure will be low. And this again, this policy talks about universal access to quality healthcare. So when we say universal access, so universal access means health for all, irrespective of their caste, creed, place, where religion. So everyone who is inhabitant of this state or this country has to be provided healthcare services, irrespective of who they are, how much they are earning, from which religion they are, from which caste they are, which color they are. So they have to be provided these services. Now objective is to improve health status through concentrated health policy. uh, when it is talking about policy, it is health policy action in all sectors, and expand preventive, curative, palliative, and rehabilitated services provided through public health sector with focus on quality. So the objective is to provide a standard or a good health services which include not only preventive, promotive, but curative, rehabilitative, and palliative care also. And these services has to be provided through public health sector. This does not talk about private health sector. So the government has taken onus of providing quality services through government facilities. So what are the principles? So if we will give, okay, let me show you the base document. So what you can see now, you can see the PPT or a Word document.
It is the PPT.
You can still see the PPT.
Yes.
Okay. So what I will do, okay, in the chat box, okay, I am dropping a document. Mm, 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 mm. So you guys can see National Health Policy PDF in the chat box.
No.
No.
No, no, sir.
Okay. What is this? कुछ मिला आप लोगों को? You can
Yeah,
see it's
I have received one.
okay. It is getting shared from my side. You guys, okay. I think it would have reached by now.
Yeah, yeah. It is visible, sir.
Okay. So this is the new guideline in the PDF format, which was released by Government of India. So this whole session is no is a gist of this document. Okay. So if you want to go and learn in detail about this document, you can refer this. So we had been discussing about the principles. So there are 10 principles, which are serving as a guiding document, guiding principles. So first one is professionalism, integrity, and the ethics. Second is equity. Third one is affordability. Fourth one is universality. Fifth one is patient-centered and quality of care. Sixth one is accountability. Second one is inclusive partnership. Eighth one is pluralism. Ninth one is decentralization, and 10th one is dynamism and adaptiveness. Okay. So the first principle, which is professionalism, integrity, and ethics, this says that this health policy commits itself to the highest professional standard, integrity, and ethics to be maintained at the healthcare system or healthcare delivery point or at the health facility by the service provider. No, and this it should be supported by a credible, transparent, and responsible regulatory environment. So the first principle talks about the professionalism, the etiquettes of the healthcare service provider, how they should be. And the second principle, which is equity. So this says that this national health policy will reduce inequity, uh, will reduce the inequity. So which mean there should be action taken to ensure that the services will be provided to the poor people. Okay. And it will minimize disparity on account of gender, poverty, caste, disability. So what this principle mean, that any health facility across India will not be providing biased services. Biased in terms of caste, creed, color, religion, or no disability. So everyone will be taken care equally, and these facilities should be inclusive. So there should not be any no geographical barriers or disability barriers. So like uh, see, these are the again the principle, and it has these talks about ideal conditions. Now, to be very frank, I have seen multiple health facilities which does not look like disabled friendly. If a person with no comes with a wheelchair, they don't have entrance which is friendly to them, or the entrance or the flooring is not very much friendly done, thinking of a geriatric population. But this policy says that it should provide equity. When so equity has to be taken care while providing services. The third principle, which talks about affordability. So this talks about cost of care, right? So it should provide uh, services which should be uh, the services should be affordable. So as cost of care has been increasing, and affordability as distinct from equity requires emphasis. So this basically this principle says that the cost of healthcare system has increased a lot, and it's hard to provide quality healthcare services to the population, because of which the government health system or the public health system ensures that services provided at these facilities has to be uh, mm, affordable. So there should not be any out of pocket expenditure done by the population, because of which mm, there should be reduced load on the uh, healthcare services. Now, fourth principle is universality. So it talks about prevention of exclusion on social, economic, or grounds of current health status. So like uh, how this is different from equity. So there also we had been talking about providing services irrespective of caste, creed. So here when we are talking about universality means everyone will be provided services. So here the angle of certain diseases, like a few decades back, TB was a stigmatized disease, leprosy was a stigmatized disease. Now currently HIV/AIDS is seen with a stigma. So this basically talks that irrespective of disease condition also, the patient has to be taken care at the health facility, and they have to cater, so the whole population has to be catered within the health infrastructure. The fourth one is patient centered and the quality of care. um, you guys can talk about quality healthcare services. Now, of lately, Government of India has multiple accreditation system. So, can someone from you unmute yourself and talk about a certain quality accreditation systems of Government of India? which is happening at your health infrastructure?
It's like the NQA certification is one of them, sir.
NQAS is the largest certification. If any facility is NQAS certified, then you don't need to bother about any other accreditation system. But of lately, how many facilities are NQAS certified in your? You people are from Manipur, right?
Yes, sir.
Okay, how many facilities are certified NQAS in Manipur?
4, sir.
4, and those are district hospital or no?
3 district hospital and 1 community health center.
Okay, and how many district hospitals are there in Manipur?
7, sir.
5, 7.
Yes, 7.
7. Okay, so Manipur is a smaller state. So there are multiple states where they have 35, 38. In fact, some of the states it's 40 plus district hospitals are there. And to be very frank, these states hardly had 2 or 3 of their district hospitals are accredited as NQAS. So, any one of you can, in brief, tell me how many departments are supposed to be certified under NQAS? कितने
Sir, at present, the Ministry of Health and Family Welfare is focusing on certification of 40 level rooms.
Okay, so altogether NQAS checklist talks about 18 departments. Okay, so if 4 of them are are as per standard and under a state by if the scoring by a state assessors crosses 75%, then they can go for national assessment to be done by national assessor, and then again if they cross that first 75 percentage of marks, they are being accredited at NQAS. So as I said, NQAS is the larger umbrella. Apart from NQAS, are there other standards which you are aware of?
Sir, Kayakal is one of them, and
Okay. Kayak,
Suman is also there.
okay, Kayakalp is there, Suman is there, very good. Anything else, Lakshya?
Lakshya is also there, sir.
Okay, Lakshya is there. Then there is a new accreditation system which is known as Muskan.
Yes, sir. Related with the child neonatal health, sir.
Exactly. So see, if you will see different accreditation system, initially government of India came with this NQAS accreditation system, but after rolling out this program for a few years, government of India realized that it's very hard to get NQAS certified, having so many departments, so much of caseload. It's very hard to look into accreditations of district hospital. So of lately, if you will see, government of India is more focused towards accreditation of health and wellness center and urban PHCs or PSCs, because these are relatively smaller facilities with few departments where if they will concentrate or focus, their uh, focus will be even 10-20%. So the quantum of accreditation, the number of facilities which are getting accredited will increase. So that's how the government of India is talking about. So that's why if you will see this accreditation system, they talk about beneficiary interview. So that's how the fifth principle, which is patient centered and quality of care. So the focus, at present the focus of government of India is not only providing facility or services to the beneficiary, but the focus is on providing quality care. Okay, so it is not only in numbers, but it should be quality focus. And then there is something called exit interview. If a beneficiary has visited your center, whether they are satisfied with the services provided over there or not. So are any one of you any NQAS assessors in this group? Because you people are working in this facility for 10 years or so. Any one of you are assessor for any of these standard accreditation system? No? Okay. So, so the fifth principle is patient-centered and quality of care. Sixth one is accountability. So it is accountability in terms of the finances which are being given to those facility, and performance. So the accountability is on both, and it should the decision which has been taken care in terms of there is a fund which is under Rogi Kalyan Samiti. So some of the facilities you will see these funds are in crores, somewhere it is in lakhs. So when that those funds are being utilized, tight funds, untight funds, this should be transparent. Why they are taking a decision to use those money for certain things. And this policy also talks about elimination of corruption in healthcare system. And this does not talk only about corruption of public health facilities. This talks about private health facilities also. So there also, if any decision is being taken, this would be accountable. Like at present, if you will see, many of the uh, uh, I'm talking about my experiences from UP, Bihar, MP, Rajasthan. These all are northern states. So what is happening? So there is a nexus, or there is a corruption which is built within the system. So if you will see, there is something called SNCU, Sick and Neonatal Child Care Unit, where the newborn infants are being admitted who are having certain disease condition. So there is a consultant pediatric doctor which is not a full time pediatric doctor hired by government. They are on consultancy basis coming and visiting those health facilities. So most of the time what is being seen, that the children are mostly not being hospitalized in the government SNCU. They are through ASA, through ANM, they are being sent to those consultant clinic which are somewhere near to the facility. Government has health facility only, and there they are being charged heftily. So similarly, a pregnant woman which is supposed to be taken care uh, free of cost at a government health system, are being sent to a private nursing home for delivery, for labor. So these are some sort of issues where there is a corruption, there is a nexus. So national health policy talks about that also, but somehow we have not addressed that. That is a different issue. So seventh one is inclusive partnership. So there are multiple stakeholders, and their participation is equally important. And then I said that convergence of multiple departments. So they can be non-health ministries also, and then when stakeholders are there, their communities also. So there should be partnership within department, partnership from community, and then involving not for profit organization. So government health policy talks about this inclusive partnership, which will be for betterment of the health of the community. Now, eighth one is pluralism. So, patients who so choose and when appropriate would have access to AYUS. So, there are multiple, medicine system within India. So, it is not only allopathy. There are other medicine system which is called AYUS, Ayurveda, Unani, homeopathy. So these all medicine system. So if a patient thinks that okay, I should be taken, no, I should go and consult Ayurvedic medical practitioner, they should go and take no consultation from them, and can be taken care by those doctors. So similarly, this holds equally for other system also. So a patient is free to take care of the disease condition and the type of medicine, the type of medical practitioner they want to be treated by. So similarly, if you can see at CHC also, you can see a use doctor. It's hard to see use doctor at PHC. I don't know, in the places where I have visited, I have not seen a use doctor at any PHC. But CHC and above, I have definitely came across a use doctor. So if anyone of you can talk about this different medicine system. Do you have a AIHMS doctor at PHCs over there or CHC? How frequently you can see a AIHMS practitioner at your health facility, government health facility? If someone can talk about that.
As far as I'm Roshan here, sir. As far as you understand, no doubt, AIHMS doctors are being posted in PSCs and CHCs.
So you are saying AIHMS doctors are posted in PHCs also?
Yes, yes, yes. They are posted in PSC, but the issue is that they do follow the allopathic medicine rather than practice their own
Okay,
AIHMS medicine.
so they are prescribing allopathy medicines only.
Yes, and because of this, strict actions have been implemented by AIHMS department so that they follow the AIHMS system of medicine rather than the allopathic medicine.
Okay, so what I understand is you are saying that AIHMS doctors sitting in government health system are prescribing allopathy medicine, right?
Yes, true.
Okay, so I don't know whether your state government has approved it or not. Like states like Maharashtra, they had came up with the guideline where AIHMS doctors are authorized to write allopathy medicines. If that guideline or that circular has been issued by your government, then that is legal to do that. But my concern is little different. Okay, so when I'm talking over here, I am putting my peace of mind, my understanding, which is not a part of this class or the guideline. I totally have a different opinion. Like these are traditional medicine schools like AIHMS. If you will see Ayurveda, Unani, these are basically traditional medicine. So if someone has studied a different principle or a different medicine, then why not to use that and using something which you have not read? So this is totally a wastage of it's a wastage of the course which they have gone through. Anyway, that is something different. Okay, so
In addition, sir. Hello.
Yeah.
Sir, in addition, now this AIHMS LL Wellness Center is also coming at the level of health sub-center, sir.
Okay, so these health and wellness centers, they are supposed to have CHO, community health officers, right? So
Yes, sir.
and yeah, so most of the states, either they are having a CHO basic qualification, either is nursing or a AIHMS doctor. So wherever they are getting a AIHMS doctor, they are preferring to place them. If they are not getting a AIHMS doctor, at least they are trying to place nursing officers, which can be BSc nursing. But in some of the states, I have came across where like states like Madhya Pradesh and Rajasthan, they are placing ANM and GNM also as a CHO. So it again these basic qualification has been tweaked as per the need of the state. So definitely multiple places I have came across these community health officers, they are AIHMS doctors. So that's what you had been talking about, right?
Sir, my submission was that above this community health officer, now Directorate of AIHMS is coming up with separate AIHMS LL Wellness Center, where AIHMS doctors are mandatory to be posted at LL Wellness Center, sir.
Okay, so you are saying, like, suppose if there are 100 health and wellness centers in a state, government is identifying 10, I'm giving a hypothetical number, 10 health and wellness center where there should be a mandatory AIHMS practitioner sitting over there, right? That's what you're saying?
Yes, sir. And this will be termed as AIHMS LL Wellness Center, sir.
Great. At least we should promote our own traditional medicines, isn't it? So homeopathy started in Germany, but as on date, I think we in India have most number of homeopathy practitioners than anywhere else in the world. So good if we are promoting our own traditional medicine system. Great. So ninth and 10th principle are decentralization and dynamism and adaptiveness. So decentralization in terms of decision making. So when you will see decision making, now the smallest unit which is working in any community is VHSNCs, like Village Health and Nutrition and Sanitation Committees. So this committee takes care of like how the health programs will run in their community, which fund they will utilize for which things. All those decisions are being taken care at the local level. So that's what the decentralization mean. The decision has to be taken care or taken by the community itself. And then the 10th one is dynamism and adaptiveness. So constantly improving dynamic organization of healthcare based on new knowledge and evidences. So this basically talks about CME, continuing medical education and continuing nursing education. So that is a part which is very dynamic. If latest research is latest evidences are coming, the healthcare provider has to be talked about those evidences, and those evidences with learning from the communities also has to be shared. So it's like the once a person who is in the healthcare system uh, has got a job, there are still opportunities wherein they can learn from ongoing CMEs, and this learning system is dynamic, and they should be adaptive to the new studies and new evidences which are coming out. Now, what are the goals which are being targeted? Now, some of these goals you might find little odd, because we are, as I said, already 6 years into this national health policy. But again, because this is the latest national health policy, so this is the only guiding principle for us, and we are following that. So this national health policy says that the life expectancy has to be increased from 67.5 years to 70 years by 2025. And when this life expectancy, this is for India as an average. This does not talk about life expectancy rates for different states. So this is average life expectancy for India as such. And then establish regular tracking of disability adjusted life years. We have already read about Delhi and Quali in our earlier classes. So this talks about that there should be regular tracking of Delhi index as a sure of burden of diseases. So we have seen how if a person is bedridden, then Delhi is calculated. So this health policy talks about Delhi as a tracking indicator for any burden of diseases. And then reduction of total fertility rate. TFR is total fertility rate by 2.1. Sorry, 2.1 at mm, 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 sorry 2.1 at national and subnational level by 2025. So we are in a year or so we will be reaching 2025. And if I am right, TFR, we are quite nearer to that to achieve that, and some of the states have already reached 2.1. How much is TFR for Manipur?
Sir, it is 2.17.
2.17. So quite near. Hopefully by 2025 we will be at 2.1. So reducing under 5 mortality 223 by 2025, and maternal mortality will to 100. And how much is your under 5 mortality rate?
As per NFHS 5, our under 5 mortality is 30. And regarding MMR, our state is a small state which do not conduct 1 lakh delivery in a year, so we are not covered in the survey report, sir.
Okay, so you are the one who is responsible for state data, right, Mr. Singh?
Yes, sir.
That's how all these things are on your tongue. Good to see, the owners and the ownership coming from your mouth. Few of the states data managers, they are not that much vocal. When you will start asking those data, they will keep looking, right and left. Good. So the reducing this document talks about reducing infant mortality to 28 by 2019. We have already passed, and we have not achieved that. We are somewhere near to that, if I'm right. So this is 30 plus still 31 or so for India. Reducing neonatal mortality to 16 and stillbirth rate to single digit by 2025. There is a big laundry list, achieving global target of 2020, which is also termed as target of 90-90-90. So 90% of people living with HIV know their HIV status. So this is first 90. Second 90 is 90% of people diagnosed with HIV infection receive ART, and then next 90 is for 90% of all receiving ART will have viral suppression. So this is the global target for 2020. We are yet to achieve that. To achieve and maintain a cure rate of more than 85% in new sputum positive, this is for TB cases, to reduce the prevalence of blindness to 0.25 per thousand by 2025, and this is burdened by 1/3 from current levels, to reduce premature mortality from cardiovascular disease, cancer, diabetes, or chronic respiratory disease by 25% by 2025, increasing the utilization of public health facilities by 50% from current levels by two. Now see, there are again missing links in this document. Now they says current levels, so they should have very clearly mentioned what are those current levels when this document was being written. So like we are reading in 2023 and still I do not remember. I am very poor in remembering those data. So what was the baseline in 2017 when this document was written, and what will be in 2025? So 2025, what we are envisaging has been written very clearly, but what was the baseline is missing. So it's hard to trace or track the development, how far we have changed. Anyways, so this also talks about more than 90% of the newborn are fully immunized by 1 year of by 2025. Meet need of family planning above 90%. This is something which we need to work hard. 80% of non-hypertensive and diabetic individuals at household maintain controlled disease status by 2025. Again, NCT is not very much focused, so this is something which we should try hard to achieve that. A relative reduction in prevalence of current tobacco use by 50%. Again, this is not in our priority, irrespective of increasing tax or so. The utilization, the number of people, the percentage of people using tobacco is towards the higher end in India. Reduction of 40% in prevalence of stunting. This is again something which we have not focused. Very recently, Government of India has published CMAM guidelines. Are you guys aware about that?
No, sir.
Okay. So what is CMAM? Do you know the full form?
No, sir.
Okay. There is something called community-based management of acute malnutrition. So these are basically those children who are suffering. Their uh, weight for height Z score is more than -3 SD. So you know what is SDA score, what is ZS score, what is weight for height, what is. This is clear to you people?
Sir, is this stunting related with BMI?
Stunting related with
BMI, is it related or not related, sir?
when you are saying MI, what does that
BMI,
mean?
BMI.
No, BMI is basically calculated for adults, right? This is something which is related to anthropometric measurements, so for knowing whether stunting, wasted, or underweight, for knowing all these things, you need to measure the child's weight or height, and then at the same time you need to know the age of the child. So in most of the conditions, especially in Indian scenario, it's very hard to know the age of the child. At least present generation, they are aware. If you will see people of my generation, I am 40 years old. So if you will ask, people might be having two date of birth, one date of birth which is their real date of birth, other date of birth which is their certificate date of birth. Okay. Or in remote setting, rural setting, if you will, at present also, if you will go and ask a mother, in which year your child was born, so they will say the year when we had received floods in our village, that year. Now you keep tracking, or you keep wondering which year there was flood in that village. So for that, no, to take care of those nuances, no, there is something called weight for height. You measure the weight of the child, measure the height of the child, plot a graph, which is a WHO MGRS growth study chart, and then on basis of that, you will see whether the child is a stunted or not. So this is something which you should know. Very recently, I think hardly a month back also, not even a month, Ministry of Women and Child Development Department has came up with those guidelines. So anyway, so this national health policy also talks about a reduction of occupational injury by half, and then national and state level tracking of health behavior is also envisaged in the document. Uh, Increasing health expenditure by government as a percentage of GDP from the existing 1.15% to 2.5%. Increase state sector health spending to more than 8% of the budget by 2020. Again, there is a difference in this data. Decrease in proportion of households facing catastrophic health expenditure from current level by 25%. Still, that out of pocket expenditure is happening. No, people are going to private facilities for being diagnosed or being treated for treatment. Ensure availability of paramedics and doctors as per Indian IPHS norms. How many doctors are supposed to be per thousand population? Any idea? If I'm right, Indian Public Health Standard says that we should have one doctor per 10,000 population. So still you go and cross check. I'm not very sure whether, but as far I remember, this is the standard which they talk about. Increasing community health volunteer to population ratio as per IPHS norms, establishing primary and secondary care facility as per norms in high priority district. So there are two type of population. One is hard to reach terrains. So those places which are hilly area, where they are very prone for floods and all these are. So there the PHC and CHCs are supposed to be established for a reduced number of population, whereas in a normal terrain, this population size increases. So the setting up of new PSCs and CSCs has to be taken care as per those guidelines. Uh, so ensure district level electronic database information on health system components by 2020, which is again a missing link. We have not digitalized our data. Uh, Strengthening the health surveillance system. How good is IDSP of your state? Do the state surveillance unit SSU, is it functional, working very good, reporting of SPL form? Any idea, Mr. Singh?
Yes, sir. We have a IDSP cell which are regularly reporting S, L, and P form, sir.
Okay. So there's something called IHIP, Integrated Health Information Platform. You are aware
Yes,
about
IP,
IHIP.
IHIP, yes, sir.
So reporting is how much percentage? 80, 85, 90? How much percentage is from Manipur?
Sir, for the S form, it was about 75.
Okay.
And L and P forms are around, IT and one is lower than IT, sir.
Okay, so for the better understanding of the other students, can you talk what is syndromic, what is presumptive, and what is lab confirmed, so that everyone understand?
Sir, I'm non-medical
No,
person, sir.
no. Okay, no problem. So S is symptomatic. If a person comes with a symptom, so which you think that symptom is of TB or diarrhea, so you without doing any further lab investigation, uh, you put them no you put them symptomatically, classify them for that disease. There is something called P form. P form is presumptive. You presume that this looks like for example pyrexia of unknown origin, so you can put presumptively over there. So third is lab confirmed. You suspect that case is of a TB, and then the person gave sputum, and then when after investigation that person has been diagnosed with TB positive, then you put that person as lab confirmed TB positive. So that's how there are at present multiple diseases which are under IDSP. If I'm right, the currently the list has been increased to 38 diseases. So for these 38 diseases, they are these are notifiable diseases. If any such diseases are being notified at any health facility, so these has to be notified under IHIP. So the more you will learn about surveillance system, the more you will know about this. So anyway, so if any state or any place uh, they focus on surveillance system, the disease outbreaks of that a disease outbreak investigation system of that place or that facility or that this state will be very good. So this is high time we should take our learnings from COVID-19 and we should focus on those. So this National Health Policy talks about coordinated action on 7 priorities areas for environment for improving the environment for health. So what are those 7 priority areas? One is Swachh Bharat Abhiyan. Second one is having a balanced, healthy diets and regular exercises. Third one is addressing tobacco, alcohol, and substance abuse. Fourth one is Yatri Suraksha. So this talks about preventing deaths from accident, road traffic accidents, by train accident. The fifth one is Nirbhaya Nari. So this talks about Nirbhaya Nari is this talks about gender violence. Uh, Sixth one is reducing stress and improve safety in the workplace. And seventh one is about reducing indoor and outdoor pollution. So these, if you will look into those 7 areas, these 7 areas are not directly comes under the purview of health department of health, but these 7 areas will definitely affect the health status of the population. So there should be a coordinated action within these 7 departments or 7 programs which will improve the health. Now the key policy shift in which you can see in organizing healthcare services in primary care, the PSCs, from selective care to assured comprehensive care. Someone is writing something. Someone has written something in the chat box.
I've just uploaded this thing, Indian Public Health Service Guidelines for 2022 for everyone.
For women.
2022.
22. Okay, IPHS guidelines you are saying.
Yeah, yes.
Okay, thank you. So these IPHS guidelines are I think everyone should go through, because in India our public health system is being ruled by that. Again, having said that, it's very hard to maintain those guidelines, these IPHS guidelines. I have privilege of working in states like Karnataka and Tamil Nadu. These states are having very good, health indicators and very good health infrastructures, but still, no, these standards are not being maintained over there. They are in a better situation compared to other parts of India, but still, ideal is ideal. There is a missing link across India in those on those IPHS guidelines. So at secondary and tertiary level, there should be an input oriented to an output based strategic purchasing. In public hospitals, from user fee and cost recovery to assured free drugs, diagnostics and okay. Have you people heard about EDL?
Yes, sir. Essential drug list.
Essential drug list. Is there any other full form also for EDL?
Essential.
Okay.
So, sir, we are implementing this free drug in the form of free drug initiative.
No. Those are the things which is being talked about in this document. Okay. Now just I'm clearing a few nuances. So off lately, we in India has been, when we had been talking about EDL, that was essential drug list. Now EDL, the previous EDL is known as EML, essential medicine list. Now the present EDL is essential diagnostic list. Okay, so there is a difference. Previously EDL was drug list, now D stands for diagnostic, and previous drug has been changed to essential medicine list. So at which healthcare structure in a public health facility should have which all medicine, and in a public health system which all facilities should provide which all laboratory test as known as essential diagnostic list. This is clear? Okay, so these shifts are there being mentioned in terms of infrastructure and policies. What all things has to be taken care? Okay, so the national health programs which comes under preview of this national health policy. So there is something called RMNCH plus A, reproductive, maternal, neonatal, child health, and adolescent health. So all these programs comes under this purview. So national health program talks about RMNCHA. Then the special focus on child and adolescent health, RKSK राष्ट्रीय किशोर स्वास्थ्य कार्यक्रम, RBSK राष्ट्रीय बाल स्वास्थ्य कार्यक्रम. So these all comes under this. Then this talks about intervention to address malnutrition and micronutrient deficiencies. So if you will see for iron anemia Mukt Bharat is the program which focuses on taking care of anemia. So digital hemoglobin meter, iron plus initiative, all these things are over there. Then for addressing malnutrition, there is something called FSAM, facility based care of severe acute malnutrition. Of lately, as I said, that government of India has came with CMAM guideline, so community based management of acute malnutrition. So these all comes under this intervention. The universal immunization UIP Mission Indradhanush MI3 we are currently being rolling out. So this is which is being taken care by the health programs. Now communicable diseases. Now these communicable diseases are National Tuberculosis Elimination Program, National Leprosy Elimination Program. So different diseases are being targeted under different program, communicable diseases. So see, control of tuberculosis, control of HIV/AIDS, leprosy elimination, NVDCP. These all vector-borne disease control program. So these all comes under communicable diseases and are being taken care by different programs. Non-communicable diseases is something which comes under NCD, and government of India has recently launched a new program which takes care of non-communicable disease. What that disease is known as? What that program is known as? Can anyone talk about that?
Sir, it is about NPCDCS.
Yes, NPCDS. So National Program for Prevention and Control of Cancer, Diabetes and
Oh,
hello.
National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases, and Stroke, I think.
Very good. So as for a stroke. So this whole NCD program is being taken care under the single umbrella. So these are separate healthcare program, and if I will, as I had been going through your syllabus, so few of the major health programs are to be taught separately. Okay, so there is a program for mental health. Now there is something called MNS. No, this is a program which is being rolled out by Government of India. So MNS is for you know. This program talks this basically MNS is a module which is being taught to the um, uh, what do I say for ASA. So MNS is over there, and the full form of MNS is can anyone say what does MNS stands for? Anyone aware?
no,
I
sir.
think it must be mental, neurological, and substance use abuse disorder, something like that.
Yes, 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 yes. Substance use disorders are there, elderly and palliative care are there. So this mental health comes under that MNS purview. And then this also talks about population stabilization, that is family planning, women's health and gender mainstreaming, gender-based violence, supportive supervision, emergency care and disaster preparedness is also focused under this program. And then there is a focus on mainstreaming the potential of AYUS, and then tertiary care services. When this tertiary care services we are talking about, basically these are no, strengthening our medical colleges, how better we can do, and then allotting human resources for health. Again, most of the states there is a issue with human resources for health. We do not have prescribed number of doctors, nurses, or paramedics. So financing for healthcare. So again, if you want to read more about that, learn about 15th Finance Commission, which came I think last to last year, which talks about certain a different funding or system finance for the improving healthcare system. Then collaborative with non-government sector, engagement with public-private sectors. These all are there. Now we will talk about NRHM. So NRHM was launched in 2005, and initially it was launched for 7 years, and then we thought how better it can be taken care. So they started with a vision where health was at the center of economic and social development, and the goal was to improve the rural healthcare delivery system and improving the quality of life of the citizen. Anyone is messaging anything? PPT.
Just,
Okay.
yes.
PPT you are not getting in the group.
Unit 3 we got, but not this one.
The class is yet to get over, right? Don't worry, you will get it. Usually I used to pass it to Seema and then she used to share. You want me to share it here in the group only itself?
It will
Then
be fine, sir.
yeah.
It will be fine.
Yes.
Pardon?
Sharing in the group is also okay.
Okay. So if basically because they are the one who are coordinating for the classes, so that's how I used to pass it to them. Anyway, if you want, I will pass it over here also, or you can take it from there also. I will do both the things.
All
Okay.
right. All right.
So the aim is to provide accessible, affordable, and accountable health services, effective and reliable primary health care to bridge the gap, and in rural healthcare through a new cadre. So ASA, what you are seeing, accredited social health activists, they were supposed to be activists who are no more activists. They are more focused towards getting salary. So NRHM is the godfather of ASA, and then they thought of coming up with a parallel health cadre, which is the lowest most cadre, no, serving 1000 population and from their own community. So this multiple vertical programs, they were supposed to be integrating at the district health society, which is DHS, at the district health level. So like multiple program, NBDCP, IDSP, RCH, MCH. So all these program, RNTCP, NLP, National Blindness Control Program, these all parallel programs were being run by Government of India, and then similarly there had been separate cells at different states. So there is a maternal cell, there is a child health cell, there is a health system strengthening cell, there is a quality cell, there is an NCDC cell. But when you go to district health society, these all converge, and these all health programs are being integrated with a DPM, district program manager. So that's how the whole system has been envisaged. So as I said, that this NRHM is the one which talk about having a cadre called ASA, then strengthening of health sub centers where envisaged under this program supply of essential drugs, allopathy as well as AYUS, sanction of new sub centers as per 2001 population, and then provision of multi-purpose worker or ANMs where there in these NRHM thing. So a strengthening of PSCs for quality, preventive, promotive, and curative services, supervisory and outreach services through adequate regular supply of essential drug equipment inclusive of auto-disabled syringes for immunization, 24-hour services. So they talk about having 24-hour services, no, having at least 50% of PSCs as 24-hour facilities, and having placement of IUS practitioners. So in my experience, I have not seen any of the larger states having rollout of this uh, IUS doctors at PSC. You people said that in your state you are having provision and implementation of standard treatment guideline, upgradation of all PSCs for 24-hour referral system, including provisioning of second doctor. Again, this is something which most of the PSCs are having only one medical officer. Either you can see say as medical officer or medical officer in charge. Yes, in states, southern states, I have seen two medical officers. In North India, this is a very rare phenomena. Now, the strengthening of community health centers were also a focus of NRHM, where operationalizing all at that time when this program came, there were 3,222 CCs were there. So they were supposed to have 30 to 50 bedded hospital, 24-hour first referral unit, including posting of anesthetist, which is again a far dream. We don't have an anesthetist at all the CSCs. So codification of new IIPHS guidelines. So those IPHS guidelines were supposed to be implemented. I have said that promotion of Rogi Kalyan Samiti for hospital management. Rogi Kalyan Samiti has been formed. A lot money are there under unutilized. Don't say underutilized. Most of them has not been utilized at all because they are very apprehensive to use that. They always wonder, if I will use that money, we will be put behind the wars, because most of those expenditures are either not transparent or not being taken care properly. So district is the core unit for planning, budgeting, and implementation of the program. So each districts are supposed to have a district health action. They should prepare DHAP, that is district health action plan. Every district should come up with their own health action plan, and then Accordingly, this district health action plan should be, in form of PIP merged at a state. So this is actually the roadmap. The blocks should develop their own health action plan, and that should be converged and merged to develop district health action plan, and district health plan action should be merged to develop a state health action plan, which is the ideal way. But this ideal way I have not seen being followed. This is just followed on paper. How do you develop your PIP, state PIP?
Sir, state PIP is majorly developed by the coalition of different program divisions at state level, and some usually they ask the districts also for some specific needs along with the justification or explanation for the same. For example, if there is an upgradation
विकास
required.
आप कौन से स्टेट से हैं?
Sir, MP फिलहाल MP.
MP, and you are working there in the government system?
I'm working with the government. I work in WHO for National TB Elimination Program for the state of MP.
Okay. So, my question is very straightforward. Is the district developing their own health action plan, or it is mere a copy paste of last 2 years? For last time the PIP was for 2 years. So is it mere a cut copy paste of 10% increase in the budget, or is this is it something which is a task where they sit and rigorously develop a district health plan based upon their priorities?
The state, it is the state which chiefly develops the this PIP, but they take district demands into consideration. But to say that they'll be merging and then compiling and then sending it upwards, it is not correct. At least for the last many years, which I have seen, it is majorly it is the state which develop. They ask from the districts what is the specific requirement. Sometimes the districts they also send, but then there is needs to be a justification. Sometimes if some construction work is required, then there needs to be a proper plan, design, etc. for that. Otherwise it is mainly the state which is involved.
That's what I am saying. That basically the whole system envisages that it will be bottom to top approach. The health action plan will be coming from facility to block to district to state. So that's how it was thought of. But looks like that most of the state, they are preparing their PIP sitting at State Health Society or SIHFW. How Nagaland, Manipur is making their PIP? If you can share your experiences.
So previously, that is before 4 or 5 years back, the district health action plans were submitted to the state, and it was reviewed at the level of secretary under the governing body or the executive body of the state health society. And the final PIP is forwarded to the ministry for appraisal. But at present, it is almost similar with what MP has said, sir.
But there's a reason to that also, because districts they prepare their plans very casually, and if you will just copy paste or just compile their plans, then there'll be a big flaw in that, which we have seen. They rarely make their plans in a sincere way, because not all the people, they just entrust one DEO, one accountant or something other, one person who do, okay, you prepare it. People who are the in charges of the program, for example in TB, the DTOs, district TB officers, etc., they will majority of them they won't pay attentions to the finer details, and then they will send it upwards. That's why the states are compelled to prepare it at the state level, because they keep an eye on it. There is a lot of discussion like that, and revisions also. That's the thing.
It's a two-way problem. We have not given that independence to the district first. Secondly, district has also not willingly taken the onus. Now a state like MP, where there are multiple development partners available at the district level, so district always has that leverage to involve development partners for developing those district health action plan, which is exactly happening at the state. If you will see a state, definitely WHO would have been a part for developing PIP for TB unit. जो उसका back end calculation होता है, definitely development partners are over there. So somewhere a state or the government system has not utilized those, not taken leverage of this system. I personally feel that if the district health action plan is being prepared meticulously, it would have been an ideal roadmap for our health system. But anyway, we should not talk about that. But I avoid why I'm talking about that and sensitizing that going ahead, that is the way forward. Until or unless district will not take interest, they will not take onus of that district health action plan, state will make some or the other thing, and then district will feel that, oh, my need was something else and we had been given something else. Anyway, so national health NRHM came long back in 2002 with a vision mission which is totally different, and then if you will see there are multiple targets. These are old targets. 2002 target, IMR को reduce करना था 30, MMR को less than 100, and then National Health Action Plan which we have read in 2017 also talks about reducing MMR less than 30. Okay, तो सोच लो 2002 से हम ड्रीम कर रहे हैं, we are still be targeting to achieve these targets by 2025. तो 2002 से 2025 we have passed 23 years and we are still yet to achieve those targets. So we need to rethink, relook at our targets. Anyways, so National Urban Health Mission जो है, this was basically a brainchild of 11th 5-year plan. So which talks about to meeting the health needs of urban poor, and this says to cover NUHM covers all those cities with a population of more than 1 lakh. The rationale of NUHM is that urban population which was estimated to 35.7 crore was supposed to increase to 43.2 crores by 2020-21, and which was a larger chunk of population in India. And because there were a multiple slum, and then this increase in population will increase in urban slums, and these slums were growing at the rate of 7% annually, and these slums are really unhygienic, where they don't have sanitation solution, they don't have potable drinking water facilities, so they don't have healthcare delivery system also. So these slum people are at a higher health hazard. They are having prone to get diseases very fastly. So the goals of NUHM is to improve health status by facilitating equitable access to quality healthcare, revising public health system, building public-private partnership to cover those population, and to reduce community-based. There's something which is very unique over there in NUHM is community-based risk pooling and insurance mechanism, and then active involvement of urban local bodies. When we are saying urban local bodies, these are mostly the corporates which are being nominated. One very unique thing of NUHM is MAS. Is anyone aware about MAS? What is MAS? MAS? Mahila Arogya Samiti. So under NUHM, they are strengthening NUHM by strengthening PHCs, by strengthening primary health system, which are UPHCs, urban primary health care centers, strengthening community participation. So community is at the pivot of these urban PHCs. Establishment of Mahila Arogya Samiti, appointment of USA, which is a counterpart of ASA, prioritizing the most vulnerable and ensuring quality health care services, because we are now people are talking about NQA certification of UPSCs also. So what is slum? Any inhabitation where at least 300 people or 60 to 70 households are staying in a poorly built, congested tenements in unhygienic environment, usually without adequate infrastructure and lacking in poor sanitary and drinking water facilities. They are either legal or not, है ना, recognized or not, is to be covered under NUHM. So NUHM, what NUHM says, whether they are legally identified or not, whether they are recognized by any government system or not, if at least if they are having 300 people or 60 to 70 household, these as per definition they are supposed to be identified as slums for UPHCs. Now these Mahila Arogya Samitis are basically, something like units of these UPHCs, and these are being nominated from the community, and they focus on preventive and promotive care, acts as peer education group. So if you will see programs like Rashtriya Kishore Karikram, so there they have envisaged about peer educators, where be identified one person from the community, one adolescent from the community, we teach them and then we mentor them, and that peer educator go to the community and will mentor their own peers. So similarly, that thing has been envisaged under MAS. So facilitating access to identified facility, and then risk pooling fund and health insurance. So if you will, what I will request that you go and read about community risk pooling and then health insurance under NUHM. This is really good. So there is a seed money and performance grant, 25 rupee per household is the seed money which is being provided by the government, and then there is a performance grant which is again 25 rupee per household which is being given by government, and this is invested no, on savings towards this Mahila Arogya Samiti, और ये फिर महिला आरोग्य समिति जो है will pass on these money in form of loans to the slum women, and this interest will go again back to Mahila Arogya Samiti. So this is something which is working on this is being provided one time fund to the these mass, and this is being used for health insurance or no for as a health insurance model. So these money is used for hospitalization, inpatient services for more than 24 hours. So this includes consultation, investigation, room charges, medicine and surgical medical procedures also, maternal and childhood illness also, and monetary coverage is up to a maximum of 50,000, and the amount is directly paid to the impaneled hospital. So this is a good model. I don't know whether you can see it or not. If you want to learn more about this, there are operational guideline of MAS which you can refer that, and then you can learn in detail more about this. So if you guys are having any question, I am available over here to address that. Otherwise, session is over, done from my side.
Sir, one clarification, sir.
Hanji.
Sir, in the slide, it was shown that NUHM is implemented in an urban population of 1 lakh, sir.
1 lakh.
In the presentation, it was highlighted, but as per guideline from the National Urban Health Mission from Ministry of Health and Family Welfare, we established UPIC for a population of 50,000.
Wait a minute. This is saying that any city which is having a population of more than 1 lakh population are eligible to have urban PHCs. Got it?
Yes, sir, I got it. But as per the UPIC norm, urban primary health center, an urban primary health center can be established in an urban population of 50,000, sir.
You are saying that urban population, right? So
yes, sir.
A city population can have both urban and rural, both population, right?
Yes, sir.
So what this slide says that in totality that city should have a population of 1 lakh. It is not talking about urban or rural population. It talks about altogether city population. So that city can have, but still I will go back and check whether there is some typo error in that. Okay, and then we accordingly modify that.
Okay, sir.
I have taken a note of that. Okay.
Sir,
Okay, thank you, sir. And second, another question, sir.
Yeah.
Sir, I have heard about national health account, sir. It is out of this syllabus, sir. But I just want to know if you can help me understand more. Is there any relationship? Is there any relationship between national health account and national health policy, sir?
National health account?
Yes, sir.
You are talking about ABHA IDs, which are being at present being rolled out.
This come under. It is one of the project under national health account, but national health account is.
When you are talking about national health account, okay. You tell me whether what I have understood is right or wrong. So at present, Government of India is talking about one universal ID, health ID for every citizen. You're talking about that only?
Yes, sir. I have come across this and I am involved in this also. But I just want to understand if there is any role of national health account in national health policy.
See, the national health policy does not talk about national health data. Okay, national health account. This is something which have emerged of lately very recently, and what I am understanding is that you are talking about unique health identifier as a beneficiary, which is not as a part of national health policy 2017.
Okay, thank you, sir.
Okay, I will look into that 1 lakh population thing. I think someone else was also trying to say something. No
sir,
question?
one more thing.
Hanji.
One more thing, sir. Sir, nowadays for the last so many years, I'm just we refer to NHM only, and National Health Mission. Usually there is no NRHM sort of thing nowadays.
See,
So it's somewhere in some states.
I totally understand that there is no more NRHM. This is being taught. The standard abbreviation is NHM, but your syllabus talks about NRHM. Okay, that's why that's why I had talked about NRHM and NUHM. Okay, now everything is NHM.
Yes,
But
yes.
okay, so your syllabus has talked about that bifurcation.
Thank you, sir.
Okay, so I will look into that 1 lakh thing, and then accordingly we'll change the slide and we'll share with you guys. Okay. Already IPHS norms has been shared by Roshan. I have shared National Health Policy 2017 with you guys. As I have discussed in my earlier class, I will share a few epidemiology books with Seema, and then she will be sharing with you guys probably by this weekend sometime. And apart from that, I have requested you to go through MAS guideline, Mahila Arogya Samiti guideline, which is a good guideline, and this is a recent updation, so you will understand things in a better way over there. Okay. Thank you everyone for being patient and listening to the sessions patiently. Thank you.
Thank you, sir.
Thank you.